Welcome to cardiology. I hope you'll enjoy this couple of weeks. You'll stay here. And in spite of the pandemic, you'll have at least 1 week the opportunity to see real patients and to see what is important for you in this area, which is a very important area. Even if you do not want to become cardiologist, every other specialty needs basic information about cardiovascular disease. Once again, you can hear me?
Yes.
Okay.
Yes.
Now, this slide shows something strange. So perhaps sometimes, of course, it's important to recognize and treat the cancers, but sometimes, as in this
I'm sorry,
guy
but I
here,
cannot hear
perhaps
you.
we are looking on the wrong direction, because it's not only the cancers, but it's mainly the discovering and diagnosing correctly.
Excuse me,
But it's
Professor.
also a matter of discovering early. Because if we discover a patient having a myocardial infarction, his risk of repeating a myocardial infarction is 5 to 7 times.
I'm sorry, Professor, we can't hear you.
Apparently, non-important disease,
I'm sorry,
peripheral artery
Professor, we can't hear you.
There's a problem with the connection and we can't hear you properly.
Hear me?
Yes, now, but it used to cut a lot.
Vă auzim pe bucăți, se întrerupe foarte des.
Vă rog atenția când
Acum se întrerupe, nu înțelegem ce spuneți.
sănim Mă puteți auzi?
Acum da, vă
Da.
putem auzi.
Dar iar v-ați blocat.
Transmisia de internet.
Da, probabil de la internet este problema.
Este la internet, dar numai că asta nu ne ajută prea tare.
Da.
Încerc acum să revenim.
Acum vă auzim foarte
Ok.
bine, dar în momentul în care porniți prezentarea, începe să se întrerupă.
Well, I'm sorry for these disturbances. I hope it will be better for the next minutes at least. Cardiovascular disease, because even asymptomatic patients, as shown in this slide here, to examine and to know the risk factors for such patients in order to recognize and treat them, even if they are asymptomatic. What is also important that patients with peripheral artery disease, which, as I told you, seems to be very unimportant, in fact, will not die because his leg pains or his leg gangrena. Most of them will die because of...
The slides. We cannot see the slides.
You cannot see the slides?
No.
And can we please also restart from the beginning because we missed a big part because it was cutting?
Yes. I shall try to rejoin. Okay. Now seeing the slides?
Yes, we can see them now.
Okay. Apparently you also hear me. I hope it will be better. There were some introductory slides showing you that sometimes cardiovascular mortality, even for quite few known diseases as the peripheral artery disease, has more importance for the patients because it gives big mortality. And it is important to recognize even asymptomatic patients having this disease, because they will die of myocardial infarction, stroke, and so on. Now, as you see, there is a big number of such events in Europe, and as you see here, there are a couple of factors which are involved. Elderly people have more frequently, the incidence is higher in elderly people. It's higher in males than in females, and it's higher in North Europe than in Mediterranean area. This is not a matter of genetics, it's a matter of food and alimentation. So we have a Mediterranean diet, which is considered to be protective for cardiovascular disease. And of course, in a world which is more and more elder, which a bigger proportion of elderly people, like in Europe, in USA, and in Japan, the number of patients with cardiovascular atherosclerotic disease will be very big, with a lot of people and a lot of cost for all this situation. It's not just a matter of cost of the acute event of a myocardial infarction or of a stroke, but it also the cost due to disability attributable to such an event. And as you see here, especially in the ex-Soviet area, they are losing a lot of active years of life due to such events. Now, where is Romania in this topic about the incidence and prevalence of cardiovascular disease? It's a bit better than the ex-Soviet area, but it's worse than Western and partly of Northern Europe. And of course, we have improved a bit beginning with 10, 15 years ago. The curve has become to decrease, but quite slowly, and we are still in a very high situation of prevalence of cardiovascular disease mortality. Now, as I told you, these patients, you have to finance the system to treat so many patients with cardiovascular disease. And what you have here is a cost of a myocardial infarction, of an acute coronary syndrome in different European countries. You see the cost is quite different, but it's perhaps a bit strange. You should say that Germany, which is very good organized and so on, should have less cost because they are organizing everything okay. Why is it not so? Any answer from the group? Do you hear me?
Yes, we can hear you.
Okay, so if I'll tell you that Romania should this help you?
Can you repeat the question, please, because it got blocked again?
Yes. Well, the question was, why are these differences between countries in cost for a myocardial infarction patient? The explanation is double. The first explanation that it costs you more if you use very sophisticated measures. For example, if you have a country where all the patients with acute myocardial infarction will be able to reach in time for interventional revascularization, as we have in Romania, but just part of the territory is covered by it, then the results will be good, but the cost will be high. The other explanation for the lower costs in Italy or in Romania are because these costs also include the income of doctors, nurses, and so on. And of course, the income of doctors, nurses in Romania, in Italy, is less than it is in Germany or in the Netherlands. Unfortunately, this is linked to the brain drain and the fact that a lot of Romanian doctors are going abroad for after finishing the university. Now we shall cut a bit discussion.
We can no longer hear you, Professor.
Sorry, do you hear better?
Yes,
Yes.
we can hear you now.
Okay.
Maybe you
Uh,
could turn off.
in any case, you shall have all this material, all the slides, so you can see them and you can put answers for the next days if you do not hear us and you do not understand perhaps what I'm doing and
Thank
what
you.
I'm saying you. Okay. So
Maybe you can try turning off your camera. Maybe that would help the connection. Because I think the camera being on is also playing a part in the disconnecting.
No way.
One second, I think he went out because he should join.
once again, do you hear?
Yes.
Yes.
Okay. So I repeat what I told you earlier. All the slides will be available for you. So if you have questions, you can put them writing on our email. Just introduction was necessary to clarify that the atherosclerosis is a very prevalent disease. It has a high mortality. It should be discovered early in life to treat it efficiently. It's a growing pandemia, and it needs a lot of coverage from the medical system and a lot of financial support in a world which has a lot of elderly people, and elderly have a bigger prevalence of the disease. What atherosclerosis means, we should talk about it after reminding you that the arterial wall has a inner wall, the endothelium, the media, and the adventitia. Yes. The intima is made of an endothelial cells and the basal membrane, which is a quite sophisticated structure ensuring a balance between pro and antithrombotic factors, ensuring the vasomotricity, so ensuring the balance between vasoconstricting endothelin thromboxane and vasodilating nitric oxide procyclins, and so on. While media will have some smooth muscle cells, and matrix is especially elastin matrix. It by non-invasive means, and one of these means is ultrasonography. What you see here is a carotid well, artery well. Yes, normally it should be like that, but this, what you see here, are atherosclerotic plaques. And so, yes, you can see peripheral arteries or carotid arteries with atheroma plaques. Same images here. You can use ultrasound for atherosclerosis, but also by invasive measures. During a coronarography, you can use the so-called intravascular ultrasound, IVUS. Yes, so this is a device. Here is the normal lumen of the vessel. Here, right, you see the vessel is almost full, no place for blood, with echogenic material, which is a atherosclerotic plaque. The most common way we designate, we diagnose coronary atherosclerosis is a coronarography, which use contrast materials, iodine contrast material, which shows the normal vessel here. But in some areas, you see little irregularities, which are atherosclerotic plaques. And if they are important, more than 70% stenosis, then this becomes dangerous for the patient. For studies and less for real life, one can also use cardiac magnetic resonance imaging. But as I told, mostly we use angiography, which is an invasive irradiating method. What you see here is the left main, the trunk of the left main, descendant and circumflex arteries, while this is a right coronary artery. As you see, the lumen of the artery is irregular. All what you see is irregularities and stenosis, like here, are plaques of atherosclerosis, meaning calcium and cholesterol. So atherosclerosis affects mainly large and middle-sized arteries, and for us, more important are the coronaries, the carotid arteries, the peripheral arteries, leg arteries, iliac femoral arteries, but it also can be present at the renal arteries, giving what we call the renovascular hypertension. What does it mean, atherosclerosis? It means intra and extracellular lipid accumulation with smooth muscle cell proliferation, conjunctive tissue and calcium deposition, secondary thrombosis in the final phase. So the first event is endothelial dysfunction. As I told you, endothelium is very important if it is normal, but if it becomes abnormal due to some levels, hypertension and so on, then the endothelium becomes dysfunctional. There is a tendency of LDL cholesterol seen here in the vessel adhesion to this endothelium, which increases its permeability and tends to favor vasoconstrictions. The LDL binding to proteoglycans present in the endothelium will get the second event, which is monocyte and T lymphocyte recruitment. So in a way, it's similar to inflammation. So the organism is trying to respond to what it considers aggression of the too high lipid levels in the blood. So leukocytes are coming here, and they give birth to adhesion molecules, to chemokines and mitogens. So this is the second event. Now this anti-inflammatory cells, the activated macrophage, are So these are a couple of data on genesis of atherosclerosis and what it means. So it's a disease which tends in years to stenose some of the arteries and increases the risk of total occlusion, acute occlusion. Acute occlusion of a coronary vessel means a myocardial infarction. Acute occlusion of a carotid vessel means a stroke. Acute occlusion of a peripheral artery means an acute peripheral event which can lead to gangrena or amputation. Now, the anatomical process is the one I showed you, but what are the causes of atherosclerosis? What can we do in order to avoid this deadly disease? The risk factor concept is, of course, important. A risk factor is a condition which is associated with a disease, statistically associated with a disease. And of course, we know about atherosclerotic risk factors from epidemiological studies. One of the studies is the classical one, is a Framingham study, which began in the United States in more than 70 years ago. So the population of a little town was screened, and now we have the third generation of people. So a lot of economic, social, and biological conditions were screened. And we know now from this data on international level, but also from some epidemiological studies that have taken place in Romania, that the main risk factors, so the condition associated with atherosclerosis, are, as you see from here, dyslipidemia, hypertension, diabetes, tobacco use, and obesity. Obesity per se is not a main risk factor, but obese people generally have also hypertension, dyslipidemia, diabetes, and so on. So yes, obese are generally at a higher risk.
Okay, I'm sorry, we can't see the presentation.
You cannot see the presentation. Let us try to get to come back to see what happened again. Okay. Can you see it now?
Yes, we can see it.
Okay. So we are speaking about risk factors of atherosclerosis. And as I told you, the main risk factors are dyslipidemia, hypertension, diabetes, tobacco, and obesity, but because obese people have a lot of other risk factors combined. Now, of course, we have limited resources, and we should know where to use them in prevention of this disease. And there are 4 categories of factors, of risk factors that we know. We shall begin with category 4. These are factors which are risk factors, yes, associated with cardiovascular disease risk, but which cannot be modified. Because we learned that aging people have a higher risk, but we cannot change their age. We know that males have a risk which is comes earlier in life, but we cannot change our sex, and even if we change it, the genetic based risk remains the same. It's also the family history that we cannot change. If we had 3 grandparents with early atherosclerosis in life, of course, this is a risk we cannot modify. So yes, we have to have them in our mind, but we cannot fight against them. Now, what we can fight against for the best, and we should concentrate our interest in this area, is a category 1 risk, so risk factors for which intervention have been proven to lower the risk. So, cigarette smoking is highly associated with atherosclerosis. If we quit smoking, yes, the risk will be lower. We shall discuss it. LDL cholesterol, high levels, high atherosclerosis. If we fight you with diet and medication, in a couple of years, the risk will decrease. Diet, better diet, yes, it's useful. Controlling the hypertension is like that. Category 2 are risk factors in which interventions are likely to lower the risk, but we have not the very clear proofs as in category 1 factors. Let us begin with diabetes. I told you that diabetes is a risk factor for cardiovascular disease. And badly controlled diabetes, so if you have high glycemia for a long while, atherosclerotic will be more probable. But strange enough, if you control diabetes, even if you control it very well, the risk still remains, and the risk is even a bit higher if you have a very tight control of the diabetes. So it's some kind of paradox with the diabetic remaining at risk, even if you control it quite well. Physical inactivity, yes, is a risk factor. Training, regular training, moderate training is useful. It can improve the situation, but the decrease in the risk is not sufficient if you do not act on the other factors I mentioned in category 1. HDL cholesterol. The HDL cholesterol is a good cholesterol. It helps the reverse process of atherosclerosis. Increasing HDL cholesterol is useful, but has not a very big impact. It's the same with triglycerides and with obesity. Finally, there is a category 3 of factors which, if modified, might lower the risk, but we do not have so many arguments, so things are a bit mixed. Let's begin with psychological, psychosocial factors. So type A personality, which are very active, very aggressive, and so on, are considered to be at higher risk. Of course, we can try to change our social and psychological behavior, but the results are not so good. What about no alcohol consumption? It's may seem to be a paradox. And it's so-called French paradox. So the French have a somehow lower incidence of atherosclerosis, in spite of the fact that they eat like their neighbors. The difference that they are drinking a bit more wine, and yes, there were some data showing that a low to medium consumption of wine, that means 1 to 2 drinks per day, not more, might be protective. But the data are controversial, so it's category 3 factor. So coming back, we have to concentrate in controlling mainly category 1 risk factors, because there we know that improving them really decreases the incidence and brings a better prognosis for our patients. There are classes of intervention. The class 1 of intervention is an intervention which is proven, very well proven by randomized trials that it is effective, and you can see here that a couple of interventions are clearly of class 1. It's easier to prove that the intervention is really active in secondary preventions in patients who had an event. But of course, it's more useful to make primary prevention. That means to block the risk factors because before the first infarction or the first strokes, or before the patients become symptomatic. So this is the role of all of you. Probably just let's say 5% will be cardiologists, but most of you of every specialty will see in his hospital, in his cabinet, and so on, patients with risk factors. So if you will tell your patient, if you are a dermatologist, please don't smoke because it's dangerous, more dangerous than your dermatologic problem. So this is an important thing. I remind you that atherosclerosis is the cause of almost 3/4 of cardiovascular death, and cardiovascular death is the main death, covering more than half of the total mortality in Romania and 40% in Europe. Now, the more risk factors a patient has, the higher is his risk. And this is so-called score chart, the 10 years risk of fatal cardiovascular disease in a population. And as you see here, you can calculate, if you have this chart, what is the risk of your patient. And of course, you can also just think about your health. Of course, your risk now is very low, even if you have risk factors. But just try to make your own risk in 20 years from now, when you'll be 45 or 50. And if you have, for example, 50 years, and you have a low cholesterol, you are not smoker, and you have normal blood pressure, you have a percentage mortality of 1%. While same age, but the patient has high cholesterol level, which is at the right of the, he's a smoker, and he has high blood pressure, he has a risk of 14% of death in the next years. So by controlling smoking, blood pressure, and cholesterol levels, you can decrease your risk almost 15 times. This is huge. So it's very important to show the patients this chart in order to motivate them to change their lifestyle and to take the medication that is recommended. Short comments about some of the risk factors we have spoken about. So smoking is probably the most important risk factor that we can influence at social level and populational level. So it's a priority of prevention. Both cardiologists, pneumologists, and others are interested in it. And as you see here, it's stopping smoking is the most cost-effective strategy of cardiovascular prevention. Percentage of smokers in Romania is around 22%, as you see here, over 25 years, but it's quite high also in young people. As you see, more than 500,000 deaths in the EU due to smoking, including lung cancer and other cancers, but also cardiovascular disease. Romania is somewhere in the middle of the prevalence of smoking in Europe. What is really dangerous? That there was some kind of increase in smoking in teenagers in Romania, and of course this should be influenced. Recently means 6 years ago, legislation was changed and smoking banned in public places. But I don't know if the rule is really respected in real life. And you should insist while being in restaurants and in public places, in your jobs, that the rules should be respected. And we are also trying to get some restrictions to electronic smoking, which is also still dangerous. Now, there are a couple of World Health Organization's recommendations concerning the use of tobacco and what measures can be taken at social level and individual level, and you can see them here. As I told you, I'll give you the slides, and you will have them available. Look on. For Romania, if you extrapolate European data, probably around 20,000 cardiovascular deaths due to smoking. Now, there is a risk, unfortunately, 2-3 times greater for a smoker of having a myocardial infarction or a stroke. There is a risk also for passive smoking. So if you stay in your smoker, your risk is increased with 25%. So it's very useful to respect the social ban of smoking in public. Unfortunately, it takes a lot of time, around 3 to 4 years, from stopping to smoke till the additional risk will disappear. But yes, half of this risk will probably be decreased at 6 months. Of course, there is a medication, and you see here a couple of products that are available. They are free on a national program to quit smoking. And if some of you are smokers and want to quit, our colleagues in the clinic is available to help you with psychological and also with medication against smoking. There are areas, countries in Europe where there is a subspecialty called tabacology, with people who are trained to help patients to quit smoking. And as I told you, there is a national program in Romania dedicated to it. Hypertension is a main risk factor, and it is very prevalent. As you see here, prevalence is increasing with increased age, with the majority of population being hypertensive in the 70s. What is unfortunate is that a lot of people do not know they have hypertension because they do not control their blood pressure. So we should encourage people which seem healthy to take their blood pressure from time to time. And that it's not only in Romania, but in every country, the percentage of people of hypertensive that are really treated and efficiently treated is quite low. So it's just a minority of the hypertensive patients that are treated to normal values, which generally are under 140 to 90. There are a couple of epidemiological studies that have been used. Both systolic, diastolic, pulse pressure recordings, all, if they are abnormal, have an increased risk. And if we decrease with just 7 millimeters, for example, the diastolic blood pressure, we shall have a big decrease of both stroke and coronary heart disease. Hypertension was the first major factor controlled because in the 20th century, in 1960, 1970, there were not yet available drugs for cholesterol levels, but there were available drugs for hypertension, and this explained why cardiovascular disease began to decline in the United States earlier in the 60s, 70s. Then, of course, with available measures for controlling cholesterol levels and with banning of smoking, the decrease has begun. As I told you, the decrease of cardiovascular mortality began earlier in the United States and in Western Europe. It's now decreasing also in developing countries, most of them. As I told, the association of more risk factors is more dangerous. So we do not automatically treat borderline levels of hypertension if there are no other risk factors. If we have a borderline hypertension, we can not use medication, but just changing lifestyle and so on. If there are no other factors, or if we have many other factors, or the disease is present, atherosclerosis is present, then we shall use medication. So there is not a cut off for using medication. It's what is important is a global risk, as shown by the scale I showed you before. So smoking, hypertension, and dyslipidemia, main factors, risk factors. You have seen this slide at the beginning when I explained a bit how atherosclerosis works and how important the lipid core is for both the occlusion of the vessel, the stenosis of the vessel, because the endothelium and the cap is pushed towards the lumen. And of course, if we have more lipids, then the plaque is vulnerable. It's prone to crack and give a acute event. Well, this is a summary of the lipid metabolism in the organism. And I remind you that from the intestines, from digestive system, kilomicrons are coming to the liver. They are full of mainly triglycerides, but also cholesterol. LDL cholesterol, low density lipoprotein cholesterol, is synthesized in the liver, and then through successive metabolic pathways, it goes to the blood and comes back. It should come back, but because of high levels and genetic disturbance of the receptors, allowing its reabsorption to the liver, we shall have high levels of LDL cholesterol, and high LDL cholesterol means high level of atherosclerosis. There are multiple epidemiological proofs, and there are multiple epidemiological proofs showing that if we lower our LDL cholesterol, we lower the cardiovascular risk. Diet is the first step, but diet, it is unfortunately in most of the cases not enough. Even with a very, very correct diet, lowering animal fat and so on, we shall have just a decrease of around 25 to 30% of the initial levels, which can be insufficient in most cases, because genetically we can have levels of LDL cholesterol which are 2 or 3 times greater than a level of 100 or 115, which should be normal. Now, there is not a same cutoff level of LDL cholesterol recommendations with all the people. If you do not have any other risk factors, yes, it may be 100 or 115. But if you have the disease, atherosclerosis is present and was diagnosed, you should have a level below 100 milligrams per 100 milliliters. Or if you have a severe disease, you are diabetic, then you should have LDL cholesterol below 55 milligrams. So generally you need medication for covering this. Classic medications are the statins, as you see here. statins lower cholesterol levels quite efficiently. And there are different products that are available on the market, and there are a lot of studies showing the decrease of mortality and morbidity using this medication. For unknown reasons, there is a quite low percentage of population willing to take these drugs. They are afraid of liver complication or so on and so forth. And it's very important to tell them there are a lot of proofs showing that the use of statins is sure and is effective. Nowadays, a new category of drugs, PCK9, which are injectable drugs, you inject like insulin, let's say, once in 2 weeks, are very aggressive drugs that can lower the levels of cholesterol in those patients where statins are not effective. I think we shall stop here. I shall send you all the slides, and if you have questions, I'm not sure you heard what I presented you. You have here a photograph. Does anybody know what it represents? Do you hear me?
Yes.
Does anybody know who is the guy here? Well, for sure you don't know, because he died before you were born. But the guy there is Professor Constantin Iliescu. So the guy who organized the cardiology in Romania. He was trained in England with P.D. White, who was one of the well-known cardiologists, and the name of our institute is Cece Iliescu, because of his presence when we moved here on the Fundeni platform 45 years ago. Questions? If no questions, then thank you for being with us. Have a safe weekend. And for those who will begin the next week, we shall see in the hospital. Bye-bye.
Thank you, Professor.
Bye.
Thank you. Bye.